We now move on to the next session. The next session will be a panel discussion on small for gestational age follow-up. The panel will be moderated by Senior Developmental Pediatrician Professor Udayakumar from Srihar, and the eminent panelists are Dr.R.V. Dhakshayani, Associate Professor of Pediatrics from Vellore Medical College, Dr.Dhivyalakshmi, Pediatric Endocrinologist from Srihar, and Dr. Rahul Yadav, Senior Neonatologist.
No, we have to understand the variation in normality. Just because somebody is small, somebody is large, doesn't mean it is abnormal. The growth charts are predominantly prepared by three sources or three ways. One is population-based growth charts, where large amount of population, we do measurements and we define what is normal, what is abnormal. Second is customized growth charts, because parity, gender, race, all these factors are taken into account, and for that particular background, what is growth is appropriate or not, we decide. And third thing I like very much, but there is this individualized growth chart. So in this, the baby's growth previously is compared with baby only. So baby to baby comparison is individualized. Baby to similar background babies is called customized, and baby to other babies is called population based. So we have to understand that examples of these growth charts are there. Frankly speaking, what growth chart you select is not important. Why we are using growth chart is most important. That's in next slide. So comparing baby with baby itself. That means what was the growth previously, now what is the growth? This is very important for antenatal diagnosis. For example, many times we in our prenatal clinic, we come across a hefty mother, hefty father, sugar slightly high, baby is growing at 50th centile, and now it is going for 20th centile. Now 50 to 20, actually that particular thing doesn't fall in SGA. But going by the background of the baby, now we are worried. And if you pick up the Liker properly, we can take out the baby at right time. That becomes a difference between life and death. So baby to other baby, and baby to parents. All three aspects should be there while looking at the growth chart. So for me, rather than selecting growth chart, interpreting growth chart and putting the clinical context of it is more important.
Yeah. So Rahul, Dr. Rahul, can you enlighten what are the consequences of these babies and why are these babies born in terms of etiology?
Yeah. So these consequences usually are correlated with why. Baby is small, baby is not growing well. Why? Now, this particular consequences, large chunk of these babies are constitutionally small and well babies. Because traditionally, our Indian birth rate is increasing. That doesn't mean that all our previous generations were abnormal. So constitutionally small but well baby is a big chunk. And superimposed on that, overlapping that, is those babies who are having hypoxemia, placental dysfunction. Second group is structural anomalies, genetic abnormalities, and torch infections. Now, each of them have got different trajectory. For example, can we go back? So each of them, this constitutionally small and well babies, actually, for neonatologists at least, it's blessing in disguise. They got less RDS, very less mild RDS, but they got more bronchomalacia. They're very easy to treat. The second part, that is hypoxemia, these are notorious because these are the babies who are actually having demand-supply relationship disturbed. Here, small baby, less metabolism, less supply. That's okay. But baby is small because of less supply is not okay. These are the babies who develop plethora of complications like shock, DIC, encephalopathy, NEC, and all those things. And these abnormal genes we can pick up not only by dysmorphism but by feeding problems they suffer. And these torch infections, obviously we know that we get multi-organ dysfunction. Many of these are self-limiting, and later on some of them they develop developmental abnormality. And last is structural abnormality. So whenever we come across any small baby, any SGA baby, IUGR baby, is that diagnosing only IUGR SGA is not sufficient. That particular baby falls in which category of it is very, very important for diagnosis, monitoring, and counseling also.
So how do you monitor these babies, Dr. Rahul?
So this monitoring wise, this one we have to understand a concept called as tracking. Suppose when you are going by highway, big highway is there are some lanes are there which are fast lanes, some lanes are which are slow lanes. Now a vehicle which is going on slow lane, that has to pick up. But if you try to cut the lane very fast, that is, that particular thing is cutting the lane very fast, that is the main problem which is facing the 21st century. What is this? Is called syndrome X, or crossing the centiles. This particular mythological picture is about Markandeya story. Markandeya story is this very useful for counseling the parents. Markandeya was a Rishi, and that particular parents didn't have child, so God asked them what type of baby you want. So he said that God gave them two options. We will get a baby who will be son, he will be very healthy, wise, intelligent, but his lifespan will be short. The second option was a stunted child with low IQ, but he will live for a long time. And he selected the former. And when the time came, then there was dilemma. This is called syndrome X. A baby who is not growing well intrauterine life, if he is overfed, is crossing the centiles rapidly, these are the babies who are prone for cardiovascular problems in life. Cholesterol, BP, sugar, sudden cardiac death, sudden gym deaths and all those things. So we have got a choice. Now what is the solution here? It is don't accept the low potential, low growth. At the same time, don't be voracious and greedy for crossing the percentiles. Cross the centiles gently. So truth is lies in between. So monitoring of SGA, we should not be too over-ambitious, greedy. At the same time, try to catch up. But the catch-up should happen gradually in a staged manner.
And what are the consequences of SGA in childhood and adolescence? Dr. Dhakshayani.
Thank you, sir. These children who are born SGA, they do not actually achieve their genetic height potential. They usually fall 1 standard deviation below their mid-parental height or even their target height. But however, 90% of these SGA children, they show spontaneous catch-up growth into the normal height range. This happens during infancy and childhood, though this is very predominant in the first 6 months of life. And this catch-up growth is usually complete by 2 years of life. But if the child is born both preterm and SGA, this catch-up growth can extend up to 4 years of age. This SGA babies, if they are born with a birth weight which is less than -2 standard deviation, when they grow up, they have a 5-fold risk of remaining short for life. However, if these babies are born with a height or length, and if they fail to achieve a proper height and they remain below the -2 standard deviation score at the age of 3 years, they still have a 7-fold increased risk of remaining short for life. So it is better to be born small for age with a smaller weight than a smaller length. But favorable factors that promote appropriate catch-up growth during infancy and childhood would include female sex that calls for survival of the female sex, and multiple births, taller parents, and more rapid weight gain during the early period of life. And both SGA and AGA babies, they do not demonstrate a very big variation in the renal functions when they grow older. They have similar renal functions, similar GFR, BP and protein creatinine ratio. Most importantly, talking about the metabolic consequences, the insulin resistance with a compensatory increase in the insulin secretion, an accelerated fat mass accumulation and obesity happens in those with very rapid weight gain in the first 3 months of life and those with a higher BMI. And as Sir said, be gentle with these children, be slow, be very gentle, don't hit hard and hit fast these SGA children because they have a higher risk of developing a bad cardiometabolic profile when they grow very rapidly. And there has been no documented evidence of increased incidence of type 2 diabetes, impaired glucose tolerance or dyslipidemia in these children with SGA during childhood or adolescence, but the picture changes during adulthood. So this is a take-home message. All SGA children need not be screened for metabolic parameters. SGA children with risk factors need to be screened for metabolic parameters. And talking about the cardiometabolic risk factor in adulthood, there has been an inverse association. Smaller the child, greater the risk of developing type 2 diabetes, hypertension and cardiovascular disease in adult life. The highest risk is seen in term IUGR cohorts, and there has been a higher prevalence of metabolic syndrome, type 2 diabetes and an unhealthy body composition, which also paves way for severe preeclampsia in SGA women who were born SGA. So that is another additional risk. So it is not advisable to attain rapid weight gain during infancy and childhood, and what is advised is a basic healthy lifestyle, a balanced diet and a regular physical activity. And there has been a documented evidence of increased risk of hepatoblastoma in these children when they develop into adults.
Good. And what are the endocrine consequences of SGA? Dr. Dhivyalakshmi.
Thank you, sir. So there are being born small for gestational age, these itself make the children at risk of having endocrine consequences. Growth has been very clearly explained by Dr. Dhakshayani. So by at the end of second year, if the child is not catching up with term baby, not catching up with growth, very unlikely that the child will catch up growth after that. Preterm child after till up to 3 to 4 years not catching up with the growth, then it is very unlikely to catch up with growth. These children are at higher risk of being landing up in short stature, and also caution to be given with the weight gain. Okay, with the weight gain crossing percentiles. Okay, it is inclining in a way and like crossing percentiles. Also, one has to be very aware. Coming to puberty. So it is said that these children they are going through puberty at an lower than the normal range. Okay, and the menarche also, the onset of menarche is also on an average is about like 6 to 7 months earlier compared to the general population. And the tempo of puberty, the progression of puberty is also very fast. It is because of this nature, this faster early onset of puberty and faster progression of puberty. What happens, one has to understand here, is that the bone age, okay, there is a small space between your epiphysis and metaphysis in your body. So till when the gap is there, when the space is there between these two bones only, the child can grow. What happens in puberty, because of the exposure to sex steroids, the space closes, and once the fusion happens, there will be no growth. Okay, so the child growing up to 18 years and all is a myth. So once puberty comes up, then there is no further growth, no further potential for additional growth. So this kind of early puberty and the accelerated tempo of puberty compromises or land up disadvantage for the adult height, as I said the reasons before. And one of the reason is accelerated postnatal weight gain play a crucial role in the early onset of puberty and menarche. However, the gonadal functions and fertility remains normal in these children. It is shown in some studies that the uterine and ovarian volume may remain small compared to the general population. Because of minor biochemical abnormalities that is associated with puberty in these children, if these children are also genetically prone, they are at higher risk of having polycystic ovarian syndrome. So there is, during newborn period, especially in the preterm children, there is a very high risk of having transient thyroid dysfunction. Bone mineral density, the concept is that you have to compare it with the height of the child. Okay, so irrespective of the catch-up growth, whether the child remains short or the child remains normal stature, the total bone mineral density seems to be lower compared to the general population in SGA children.
Good. And what are the genetic causes of short stature in SGA? Dr. Dhakshayani.
There is a very long list for the causes of short stature in SGA, sir. The most common single gene disorders with a normal head circumference and proportionate short stature, those include are commonly encountered growth hormone deficiency and growth hormone insensitivity and Laron syndrome as a part of it, and acid-labile subunit deficiency and a variant of the Russell-Silver syndrome and Noonan syndrome. Single gene disorders with a normal head circumference and a disproportionate short stature include our skeletal dysplasias, including our achondroplasia, hypochondroplasia, and shocks associated short stature. Short stature anomalies with non-specific skeletal abnormalities and brachydactyly is also found to be associated in children with short stature when you have monogenic disorders. So monogenic primordial disorders with microcephaly include those with insulin-like growth factor 1 deficiency and resistance to IGF-1. Primordial dwarfism with microcephaly include our syndromes, the Cornelia de Lange, the Meyer-Gauguin, MOPD 1, 2 and Seckles. Most of these syndromes, they do not occur in isolation. They are part of major malformations. So they are commonly associated with developmental delays, intellectual disabilities, and you can easily catch them because they have typical facial features. They have associated developmental delays and microcephaly, all that stuff. DNA repair defects with microcephaly have been increasingly recognized, and these children, they have an increased tendency to develop tumors, and probably looking back they would be Bloom syndrome children or Fanconi anemia children, and with epigenetics playing a role more than what was perceived earlier, all imprinting disorders and methylation disturbances have come to visibility, the most important being the Russell-Silver syndrome, where we have a methylation defect, and these children have growth restriction both intrauterine and extrauterine. They have a craniofacial disproportion with a large forehead and small triangular facies and syntactile web fingers, all that. You can easily catch them. And all other syndromes including temple, Prader-Willi, pseudo-hypoparathyroidism and pseudo-hypoparathyroidism are common causes of short stature in SGA children.
Yeah, good. Actually, what you have to do is whole exome or whole clinical, whole genomic sequencing. Apart from that, I think if you are suspecting SRS, Silver Russell syndrome, you may have to go in for specific methylation tests. So that is very important. Yeah. So what are the diagnostic approach to short children with SGA? Dr. Dhivyalakshmi.
Thank you, sir. Before discussing the diagnostic approach, I would like to just highlight SGA as a cohort. They are neonatologist babies because they have neonatology complication. They are developmental pediatrician babies because they have a developmental issue. They are also endocrinologist babies because they have endocrine consequences for sure. So there are certain children who you have to give an early referral to pediatric endocrinologist by birth, very preterm children, less than 28 weeks of age, severely SGA, whose birth weight and length are less than -3 standard deviation, and by anthropometry, especially when the child has a short parents or the child is syndromic like a Silver Russell syndrome, having dysmorphic features, malformation, microcephaly, development delay, intellectual disability or features suggestive of skeletal dysplasia. These are the children one has to give an early referral to the pediatric endocrinologist. Like how you approach a child with a short stature, detailed history, physical examination, measure all the anthropometric parameters, weight, height, head circumference, body proportions, comparing it with the mid-parental height, plot it in the growth chart, appropriate growth chart, 0 to 5 years WHO, 5 to 18 years of age, use IAP 2015 charts. And then if you find the child is falling less than the 3rd percentile or so, we investigate the child. So systemic screening is routinely needed to rule out non-endocrine causes like chronic renal failure, renal tubular acidosis, chronic liver disease, etc. And endocrine workup, one has to do thyroid function test along with the IGF-1. IGF-BP3, if the level comes normal, IGF-1 level comes as normal, you can do an IGF-BP3 as well. Growth hormone stimulation test in general, like routinely, is not needed in SGA children. Only if the endocrinologist suspect a growth hormone deficiency, you can do. Skeletal survey, in selected cases, if you find there is a body disproportion. And definitely in girls, do a karyotype with especially mentioning as 50 metaphases to rule out Turner syndrome. And also genetic studies is, doing genetic studies is very important. I'll just briefly go through this flow chart. So if you find there is a body disproportion, so it is skeletal dysplasia, and it is worthwhile referring the child to a geneticist and also getting a genetic testing like a whole exome sequencing or so is very important. And the other important place where you will, where I would encourage referring to a geneticist and as well as genetic testing is the presence of syndromic short stature. Like for example, dysmorphic features, microcephaly, malformations, intellectual disability, etc. Even if I find the child has a growth hormone deficiency or a problem with the IGF-1 axis, still I would like to do a genetic testing to confirm the diagnosis, because these children are at risk of having a other associated genetic abnormality in the growth hormone IGF-1 axis. I could not find any other cause, like the child is short but I could not find any other cause. It is idiopathic or an isolated short stature, and these are the patients where once again doing a genetic testing is important. So the recent international consensus highlights the importance of doing the genetic testing.
Yeah, this is a development conference, so people will be expecting the neurocognition. So what are the neurocognitive issues in children with SGA? Dr. Dhakshayani.
In the intrauterine life, the proliferation, the differentiation and the migration of all the fetal neurons is determined by genetics, epigenetics and the environment. So, the genetics, basically the person can be genetically normal, but epigenetics determines how you read the gene. It is influenced by the behavior and the environment, which means it is reversible. So this an epigenetic influence has a very large role to play than what is actually being imagined. The normal pre and postnatal growth of the brain appears apparently normal in children with SGA due to the brain sparing effect. However, certain areas like your cerebellum, the hippocampus and the cerebral cortex are vulnerable regions. So that is why these children with SGA have more profound effects on memory and attention. And in intrauterine life, the intrauterine malnutrition causes downregulation of the growth factors in the central nervous system and also causes alteration in the synaptic plasticity, particularly in the hippocampus. And that is why these children, SGA, IUGR babies, they have an impaired spatial learning and memory deficits with poor attention span. And these children, they also have significant changes in the EEG. They also persist into childhood, also into adulthood, and this is also associated with adverse neurodevelopmental outcome. Majority of these children, they have an average IQ of more than 85. Some may have an altered academic performance, altered relationship issues, cognitive impairment, and as said earlier, memory issues. They fare poorly in gross motor, language, social and adaptive domains. And very preterm SGA babies, they definitely have an increased risk of developmental delay, ADHD, impaired cognition and learning disabilities. These are the children with poor school absenteeism due to poor school performance, and they also have lots of behavioral problems.
Thank you. And how will you manage these children in the newborn period, Dr. Rahul, to improve the outcomes?
Yeah, these babies are different than preterm babies. Our neurology is obsessed about prematurity, but in India, especially this prematurity with SGA is a very common problem. In these babies, we have to see right from brain to the tissues. Brain, upper airway, lower airway, alveolus, interstitium, pulmonary vasculature, heart, and these tissues. In brain, what happens is that these babies, as actually the previous speaker mentioned very nicely, myoclonic jerks are becoming more and more common nowadays. They are earlier there, but now we are recognizing them. So these myoclonic jerks are very common if you pick them up and treat with appropriate anticonvulsants. So phenobarbital has caused a lot of problems in short term and long term in neurology and afterwards. Apnea, cognition problem. It is being replaced with another drug called levetiracetam. The beauty about levipil is that it does not affect the neurodevelopment adversely. In fact, the apoptosis of neurons is actually found to be in animals, animal studies decreased. So this one, low threshold for levipil, diagnosis of myoclonic jerks goes a long way in improving immediate outcome as well as long-term outcomes. These babies don't develop much of RDS. They are very easy to treat actually. Surfactant require very less. But they develop bronchomalacia, airway malacia. They have a lot of distress, but clear lungs. So limited use of surfactant and more use of CPAP. Next thing, these babies are prone to pulmonary hemorrhage. In India, majority of SNCUs are afraid to use surfactant because once you use surfactant, they bleed. Pulmonary hemorrhage is the very, very important part of these problems in SGA in newborns in India. So these babies, before giving surfactant, supporting the heart with inotropes goes a long way in these babies. Pulmonary hypertension is very common. These babies develop shock very commonly, polycythemia, hypoglycemia. So overall, if you monitor, the lungs will give less importance and other systems where to give more importance in SGA, then short-term and long-term outcomes are excellent. Another word of caution here is hypoglycemia. Here these babies, sometimes we start with same sugar for all babies. If the baby is SGA, classical example is, we have been taught in last century, 1 kilo baby. Less than 1 kilo baby, use different concentration of dextrose. More than 1 kilo baby, different concentration of dextrose. But nowadays we understand that weight doesn't matter, SGA present or absent matters. If SGA is there, IUGR is there, err on the side of higher GR, like 6 to 8 mg per kg. Second thing is, hyperinsulinemia is very common in these babies. And if you use diazoxide in these, it has been found that outcomes actually go down. So this insulin in these babies is actually blessing in disguise. Even if blood sugar is low, avidly that sugar is taken into cells. So this over-aggressive management of this hypoglycemia also can be actually backfiring. So we have to treat individually. These less use of diazoxide, more use of GIR, the liberal use of this oxygenation, inotropes, limited use of surfactants, liberal use of CPAP, and low threshold for levetiracetam. This is the summary of neonatal management of this SGA, which will go a long way in improving ultimate outcome.
Thank you. And we are talking about SGA with associated short stature. So what will be the role of growth hormone therapy, and how will you, what is the dose, and how will you monitor the therapy? Dr. Dhivyalakshmi.
So the indications for growth hormone therapy in SGA short children is as per the international guidelines, consensus guidelines. It is by the age of 2 years, if the child's height is less than minus 2.5 standard deviation, one has to initiate growth hormone. And 3 to 4 years of age and the height SDS is less than minus 2 standard deviation, then again it's an indication for starting growth hormone. How much to start? It is 33 to 67 micrograms per kg per day. And the dosage, start with the smaller dose because the one thing is, when you monitor the IGF-1 level, because these children are at higher risk of some genetic mutation, certain chromosomal breakage syndromes like Bloom's, Fanconi's are more common in these children. So that's why start with a smaller dose and then increase it upwards based on the IGF-1 levels and the height gain that happens every 3 to 4 monthly. And the predictors of growth response is age at initiation. The earlier you start, the better will be the growth. The longer you treat with the growth hormone, again the better response is seen. And lower height SDS at the start of growth hormone therapy, height gain that happens during the first year of therapy, higher length, relatively higher length at birth, and higher height of the mother. So these are some of the parameters that are associated with good response to growth hormone therapy. So how to monitor is by the height gain that happens every 3 to 4 monthly. You are supposed to check the anthropometric parameters, and also IGF-1 at the initiation, like few months after initiation, and then annually IGF-1 levels. Bone age is something we routinely do, but in SGA one has to take with a caution, because there is the risk of having a mild skeletal dysplasia is so high. The bone age is not very predictable. It is not very predictable with regards to adult prediction of adult height. So one has to be caution when you are following up with the bone age.
Yeah, good. And now that a lot of district early intervention centers are available, so and maybe a lot of district-wise developmental units are available. So how do you think they can follow up these SGA babies? Dr. Dhakshayani.
Thank you, sir. With this early intervention centers springing up under the auspices of NHM in all government district hospitals and the medical colleges, and also other tertiary care centers, this has played a very significant role in the follow-up of SGA babies. These babies should be carefully followed in the first years of life to evaluate their growth, weight gain, head circumference, and neurodevelopment, because neurodevelopment is the key, and that is the crux when people are craving for JEE, NEET exams. Neurocognition is of much more significance than physical growth per se. They would prefer short babies entering medicine, engineering, or IIT rather than physically fit ones entering other courses. So close monitoring of weight and length trajectories is needed to identify any malnutrition that may ensue, to pick up growth faltering at an earlier point of time, and also excessive weight catch-up, which is not ideal and which is not advisable in these SGA babies. So that calls for avoidance of additional nutrition supplementation to healthy infants up to the age of 6 months. Even if they are SGA babies, we don't have to unnecessarily burden them with extra nutrition, thinking that they would grow faster. And as said earlier, we'll have to be gentle and slow on them unless the infant suffers from malnutrition, which is picked up by the height trajectory and the length and the weight trajectory. We don't have to very much intervene into their growth profile. Excessive postnatal weight gain should always be avoided, because as noted earlier, it is always associated with a less favorable cardiometabolic health profile in adulthood. So early screening for neurocognitive impairment is mandatory in these SGA children who are born preterm, and also in SGA children who have a very complicated, turbulent and uneventful perinatal period. Otherwise, we'll have to essentially follow the norms that are being given by the government or the protocol that is adhered in the early intervention center. Ideally, 5 visits are indicated in DAC according to protocol, and that can be devised or revised as needed.
Yeah, thank you. And before questions, I think what could be the take-home message out of this lecture? I want few audience to speak because we have another 6 minutes to go. I know many of them I can call by name, but have you all understood what is SGA? The definition part of it. And I think, see, as a developmental pediatrician, we feel when a child has cortical visual impairment, we feel a lot of opportunities to manage hypoglycemia in these babies in the newborn period has been missed. So we have to be doing what is called as anticipatory monitoring of glucose levels and optimizing the glucose levels. That is very important. And I think if you can see the case sheet, the one thing that may be missing in many of the case sheets is a head circumference. Because the head circumference at birth is going to tell you whether the baby has had a very good brain growth in utero or maybe pointing to some syndromic conditions in utero. And how the head circumference grows in the next 2 years, that is going to decide how the baby's development is going to go in the next few years. In the same way, the monitoring of the weight and length, that is also very important in the initial 6 months, because that is a period where there is a lot of metabolic programming happening in the baby. So that is a phase where you have to see that you are not overshooting and you are also not pushing the child into malnutrition. And all these babies definitely will be requiring close developmental follow-up over at least the first 5 to 10 years, because a lot of learning issues can crop up only beyond 5 years of age. And I think together, I think if you take a pledge to see that, because they form sizable proportion of the population, the percentage wise. So maybe like say 25-30% population may be SGA in India, country like India and other low and middle income countries. So maybe I think we need to focus on this group with special attention and focus so that we can improve the outcomes of these babies later. And I thank the organizers for the opportunity, and I thank Dr. Rahul, Yadav, Dr. Dhivyalakshmi and Dr. Dhakshayani for the wonderful effort they have put in. Thank you all. Any questions, I think you can send it across. We'll be able to answer at the end of the session. Thank you.
Thank you, dear faculty, for the wonderful session. Request Professor Udayakumar, Dr. Dhivyalakshmi. The first question is, what is the role of supplements like medium chain triglycerides, iron, multivitamin and vitamin D3 in SGA babies?
Yeah, I think if you are going to give breast milk, and that should be sufficient. I think medium chain triglycerides, if it's indicated based on gestational age, may be given. So, but we have to see that the child follows a normal growth trajectory. But I'm more, I think the question is very well asked, because iron is a very important nutrient, brain nutrient, which we miss in the first 2 years of life. Because we all know, like all preterm babies, majority of them are getting iron supplements. That is good. But for term babies, they are not getting iron supplements. Although I think our studies show like maybe close to 70% of children between 6 to 24 months may have iron deficiency, anemia. But we are not looking at iron deficiency as such. So this is a very good question. I think standard guidelines, AAP guidelines says iron should be supplemented RDA, 1 milligram per kg for all AGA babies term. So in that case, I think it should be applying for SGA also. Multivitamin, maybe based on the need, I think you can add MCA, medium chain triglycerides, maybe if it is indicated on preterm side, can be added, but not for SGA. But I think IAP can also take up steps for including these recommendations on iron supplements for term babies. It is usually started at around 4 to 5 months, and I think we need to have some more studies to see like how these babies do well in terms of developmental outcomes. It's a good question.
Thank you, sir. Question to Dr. Dhivyalakshmi. Should transient hyperthyroidism in preterm be treated? If so, what is to be done?
So, transient hypothyroidism in preterm children, as per the ISPAE guidelines, we have a time up to 3 weeks of age. So anyways, preterm children, we have to do a repeat thyroid function test at 2 weeks of age and see. I would suggest, like, if the TSH is falling, FT4 is remaining in the normal range, then you can carefully do a wait and watch, provided the patient will definitely come for follow-up. So if the patient is not going to come for follow-up, the treating physician is doubtful, please start the child on thyroxine. By giving thyroxine, you are not going to create any harm to the child. Okay, if the child is not going to come for follow-up, I think if the TSH is increasing by 2 weeks of age from the starting value to the repeat value, then I think that's an indication to start the child on treatment. The dose is usually 10 to 15 micrograms per kg per day. You can crush the tablet and mix it in breast milk, and I mean, it is tentatively given like at least 10 minutes gap before feeding the child. Don't mix and give in formula feeds or try to give it with any other medications. It has to be taken separately as much as possible. Thank you.
Thank you, Dr. Dhivyalakshmi, for clarifying the doubt.